Good morning. My name is Aspetar. I'm head of hand and wrist surgery at Aspetar Orthopedic and Sports Medicine Hospital in Doha, Qatar. I'm honored to be presenting to you today on my thoughts on sports injuries of the hand and wrist and what special considerations we have in treating athletes. I have no financial disclosures or no conflicts of interest. I work at Aspetar Orthopedic and Sports Medicine Hospital that you see here. Aspetar is part of Aspire Zone, which is a 2 million square meter facility in Doha, Qatar, that contains a sports hospital, sports training facilities, a sports education school, and one of the World Cup stadiums for the World Cup Qatar 2022. Aspetar itself is one of 10 FIFA medical centers of excellence in the world. It is an IOC sports injury prevention center. It is part of the Asian Football Centers of Excellence, and it is also the PSG medical partner. What we can offer athletes at Aspetar includes both hand and orthopedic surgery. We do sports medicine and athlete screening. We have a very large rehabilitation facility with hydrotherapy and hand therapy as part of that as well. We have MSK radiology and cardiology. We have a research department that produces about 150 publications annually. And in addition, we have sports dentistry, sports podiatry, sports nutrition, and sports psychology. I would like to talk to you today about what sort of considerations we as hand surgeons must take when we meet and treat athletes. Consideration number one that I want to discuss is that the athlete is never alone. This is pretty much what it looks like when I have clinic and I see one of my athletes. What you see here is the athlete looking very grumpy that he or she is injured, realizing that their season might be in danger. This is me trying to explain to the athlete what's going on, but not only to the athlete, to the entire team that is there. In the back you have the coach trying to figure out how to change his strategies for the season. We have the team physician trying to get along and see what's happening with the athlete. But finally, we have a very important person, which is usually in the background, and that is the manager, thinking, I wonder what this is going to cost me. So let me give you an example. This is one of the national top team football players in the Middle East. He's a field player, and he came to me 1 week after he was injured on the field. The team physio performed a direct reduction during the game. And of course, the coach is thinking, just put some ice on it, it's going to be fine. Well, we went on and did a CT scan of his hand, and as you can see, in this case, we have a comminuted intra-articular fracture of the 5th metacarpal. Clinically, there is also an abduction deformity of the digit and an ulnar deviation malrotation. So after seeing the X-ray and the CT scans and clinically evaluating this patient, we decided to proceed with scheduling him for surgery. The plan for surgery was to do an open reduction and internal fixation using a bridging plate according to AO principles. Well, 2 days later, when it was the day to perform the surgery, the player suddenly canceled. And the reason for him canceling was that the manager had a request that he should not do surgery as there were too many games coming up. So in this instance, the player wanted to have surgery, but he was unable to do so. So sometimes when you're in a team like this, it doesn't really matter how much you try to prove that it's medically indicated to do a case. In the end, it's the manager that is the boss. Consideration number 2 that I want to bring up today is the importance of understanding the sport that your athlete is engaged in. On the picture, you see a cricket player You have to understand that I am a Swedish hand surgeon, and just as you, I am more focused on sports like ice hockey, winter sports, and handball. Well, just a couple of weeks ago, I had one of the top cricket players in the world coming to see me, flying into Doha for a second opinion. He had chronic elbow pain, and to try to understand why this cricket batter was having chronic elbow pain, I spent a good couple of hours the day before reading on cricket, analyzing cricket batters on YouTube, and seeing in slow motion how they are functioning. From this, I learned that a cricket batter has things like a front hand. The top hand is important. They work with a high elbow with extreme supination to pronation motion, and depending on their type of season, they can have extremely high batting rates. The patient will, of course, appreciate that you've taken the time to really get into his or her sport so that you can have a proper discussion about why pain and why injuries occur. Another example of this is a taekwondo athlete on an Olympic level that came to me with a left hand fifth metacarpal fracture. He had had a prior fourth metacarpal fracture, as you can see, with shortening, but now he had a new transverse fracture with a volar angulation. When you look at taekwondo as a sport, it is very important to realize that the ulnar side of the hand and the ulnar digits are important both for a defense and an offense maneuver. The offense maneuver is called a knife hand strike, which was what the patient had done in this instance, leading him to sustain a transverse metacarpal fracture. If we look at the fracture, it is an unstable type of fracture, and there was slight malrotation of the digit. Based on this, we decided to proceed with surgery to stabilize his fracture. Normally, I think plate fixation is great, but in a patient that is a taekwondo athlete, doing a knife hand strike, the plate will end up being very bulky, and it will also cause pain on impact. The second option, of course, can be intramedular screw. Well, once again, in a patient that places so much load and direct strikes on the ulnar side of the hand, there is a risk that the screw will bend, and the hardware, when it's intramedullary as a screw, is very difficult to remove. So taking all of this into consideration, we decided to proceed with intramedullary pinning. This intramedullary pinning was done using the S-shaped pin, which allows for a 3-point fixation, stabilizing the bone so you don't have rotation of the fragments. 4 weeks after pinning, we went for pin removal, but already at this point, the athlete had full range of motion in the digit as early range of motion was allowed. He returned to training that very same day that the pin was removed, and he was allowed to go for impact 2 weeks after pin removal. In a recent publication on analysis of different operative techniques for extra-articular fractures of the phalanges and metacarpals, it has been found that there are basically similar outcomes between intramedular screw, plates, intramedular pinning, and K-wires. So with a fracture like this, don't just look at the type of osteosynthesis you want to do. Look at the whole picture with the athlete and the athlete demands. If we move to consideration number 3, it is that we always have to remember that the athlete is working against time. And time in this instance is both time as with regard to the athlete's performance, time with regard to the athlete's age, and time with regard to the athlete's contract. Another top team football player in the Middle East, but a goalkeeper this time, came to see me with this finger. He presented 2 months after injury with a complete dorsal PIP dislocation. The athlete was informed by me that there was a need for surgery because, come on, the dislocation had been there for 2 months already. But both he and the coach insisted that we should try to do a digital block and reduction in the office. So I went ahead and I blocked that finger, and then I started pulling on it. Of course, it wasn't budging, but we tried. And the post-reduction x-ray shows this. It of course didn't work. So once again, I suggested to the athlete that we need to do an open reduction to get that joint in place. But the player fully denied surgery. The reason that he decided to deny surgery was that he was on a limited contract. He had a deadline with regard to his contract with the team. At the same time, he is the one person responsible for supporting his whole family in his home country. And so he decided that he wanted to come for a new opinion after the football season was over. This is the patient coming back 5 months later. I saw him just 2 weeks ago in my clinic. This is now 8 months after the injury. As you can see on the x-ray, there is still a complete dorsal PIP dislocation. There is an impacted fracture into the joint. There is a destruction of the articular surfaces both on the middle and the proximal phalanx. And if you look at the video, the patient has pretty much 0 degrees of motion in his PIPJ. So the question is, how can this player play at all? Well, remarkably, this goalkeeper said to me that he has no pain. He has played the entire season as first goalkeeper for the team, and he has been able to renew the contract for the next year. So how can he play with a complete PIP dislocation? Well, if we look at the goalkeeper and we look at the goalkeeper's hands holding a football, what we see is that the goalkeeper actually has slight flexion only in the MCP joint, whereas the digit itself is quite straight, pretty much the same position that his finger is constantly in. So he is able to do his job as a goalkeeper, but of course his joint in the future will not be a good joint. He is informed that there is a high likelihood of future fusion or implant surgery. Fourthly, one thing to always remember is that the work that we do as hand surgeons can be life-changing for the athlete. And it can be life-changing in both a good or a bad way. As a surgeon, it is very tempting to think that you might become a famous surgeon by treating a famous athlete. Well, it's very important to remember that when it comes to athletes, we have to be cautious. And we have to remember to not do things that we don't know 100% for sure we can manage. I had a professional motorcyclist come to me that was treated at an outside hospital for a proximal pole scaphoid fracture. He was told by his treating physician that everything had healed well, so he returned to sports. But he had severe pain after every training session and every competition. But remarkably, he kept on training and he kept on competing for 4 years before coming to see me. This is what the CT scans look like. And if you look closely at these CT scans, you can see that there is at most a fibrous union or a non-union of the proximal pole of the scaphoid. The pins are markedly displaced and they are creating an impingement into the radiocarpal joint, which has now caused the destruction of the scaphoid fossa and osteoarthritis of the radiocarpal joint. What I did for this athlete was that I performed a pin removal, an arthroscopic debridement of the synovitis, and then informed him that there is a high likelihood that he too will need future surgery as a PRC for core diffusion or other options. If we look at scaphoid fractures, these consist of 80% of all carpal fractures. They are very common in goalkeepers in football, and they appear after fall on an outstretched hand or a hard ball against the hand. In an effort open review from 2020, Clementson, Björkman, and Thompson reviewed acute scaphoid fractures and presented guidelines for diagnosis and treatment. What they proposed was that when you look at the distal scaphoid fractures, you can allow a wrist cast or an orthosis for about 4 to 6 weeks, and only if you have a displacement of about 1.5 millimeter or more should you consider surgical treatment. For the scaphoid waist fracture, this is by far the most common that we see in athletes. We can allow a short arm cast for 6 weeks if the fracture has less than 0.5 millimeters of displacement. However, if we come to a displacement of over 1.5 millimeter, we know that there is a 4.4 times higher risk of non-union. And so in these instances, the surgical treatment is the only way to go. Let's go to the scaphoid proximal pole fractures. And as you know, the proximal pole has a high risk of avascular necrosis. So for these, you may consider a short arm cast for 10 weeks, but in most cases, the proximal pole fractures should be treated by surgical treatment, normally through a dorsal approach to fix the proximal pole fragment. But should we fix all scaphoid fractures? Well, in a review by Diaz and co-workers, they came with an algorithm for how we can make decisions for treating a troublesome bone. And their conclusion was that no, not all scaphoid fractures should be treated with an open reduction and internal fixation or a minimally invasive procedure. The reason for that is a very high majority of the scaphoid fractures that are treated by screw fixation end up having problems with the screw penetrating into the STT joint or the radiocarpal joint, and also that the implants are very hard to remove. So even in athletes, if the fracture is in the distal pole or in the waist, you may consider non-operative management if the fracture is non-displaced. Of course, we all know how difficult it is once a scaphoid fracture decides not to heal. In these images, you see a natural evolution of a snack wrist from 1956 to 1982, when there is a complete snack wrist with advanced osteoarthritis of the carpus. In this instance, if it happens to an athlete, this can truly be career-ending, as the scaphoid non-union advanced collapse can only be treated with salvage procedures of the wrist. This is one of the most extreme examples of athletes being not happy with their surgeons that I have seen. This came out in February of this year. An American football player, a former Eagles captain, Chris Maragos, won a $43.5 million lawsuit against his treating orthopedic surgeons. He won it based on medical negligence, and the motivation was the following. The lawsuit alleged that Dr. Bradley and the Institute ignored prior damage to Maragos' meniscus while surgically repairing and rehabbing a torn posterior cruciate ligament in his right knee. So the complaint was not in this instance about the new injury that these doctors took care of, but the fact that they did not treat an old injury at the same time, leading to an onset of osteoarthritis and cartilage wear, and that he could not return to his sport. I believe we are all lucky that we are not working in a country where you can be sued for $43.5 million, but still we have to remember, As surgeons, we can affect our patients' lives, our athletes' lives, in both a good and a bad way. But with a risk of a lawsuit like this, why should we treat athletes at all? Well, I showed this picture in the beginning. And this picture is me and the coach and the athlete and the team physician and the manager. And this is the teamwork around the athlete. And the teamwork around the athlete is very inspirational because it allows you to cooperate with like-minded individuals who all have one thing in mind, and that is to try to find a way to get the athlete back to his or her sport as soon as possible. When you look at different sports, there is a huge challenge in understanding what each sport entails, what each athlete needs with regard to hand, wrist, elbow, and shoulder function. This challenge is very inspirational as a surgeon because you never know what you're going to encounter, and you always have to be creative in thinking about how to deal with the athlete. And finally, the joy. When you have an athlete that comes in after a bad injury and you treat the athlete through surgery, and then you can follow that athlete returning to his or her sport on the same level or a higher level as before. That is the joy of treating athletes. If you want to know more about what I do in my work at Aspetar, I post quite regularly on my Instagram and LinkedIn, and you can follow my publications on ResearchGate and my talks on YouTube. I would like to thank you all very much again for this opportunity to speak to you today and give you a little flash about a course coming up at the end of October on wide awake and minimally invasive hand and wrist surgery. We will be doing a cadaveric skills course on arthroscopic, endoscopic, and ultrasound guided skills. Thank you very much.